Hi friends, today we'll discuss the topic management of thyroid eye disease. It remains challenging for all clinicians for evaluation and management of thyroid eye disease. Today we'll discuss the management guidelines as per recent American Thyroid Association and European Thyroid Association guidelines. So for proper management, we have to follow these 5 steps. First is we have to diagnose the Graves' disease accurately. Second, to screen all the patients, those who are Graves' disease, for thyroid eye disease in every visit, and alert the patient regarding the risk of thyroid eye disease. And we have to prevent the thyroid eye disease development and progression, and refer to specialist clinic as early. And during diagnosis of Graves' disease early, we have to ask for thyroid receptor antibody. In the evaluation of thyroid eye disease, you have to look for the activity score, that is clinical activity score. In clinical activity score, there are 7 points. In 7 points, either one is pain it contains 2 points, pain, then redness and swelling. In the pain there is 2 points, redness is 2 points, and swelling is 3 points. In the pain, either it may be spontaneous retroorbital pain or the pain on a movement, that is pain mostly attempt in the up or the lateral gaze of the movement. Then redness, in the redness either there is redness of the eyelid or redness of the conjunctiva. Then in the swelling, either there may be swelling of the eyelids or swelling or inflammation of the caruncle or the plica, or there is another is conjunctival swelling or conjunctival edema. This is also known as chemosis. Then when we will tell it active thyroid eye disease, we will tell it active thyroid eye disease when the CAS score is more than or equal to 3/7. Then it will tell it active thyroid disease. Then other conditions, such as if you will see further, there is progression of the thyroid eye disease based on the subjective or objective worsening of the vision, or the soft tissue inflammation, or the motility defect, or in the proptosis, there increase in the proptosis, then suggest of there is active thyroid eye disease. So besides the score more than more than equal to 3/7, other conditions like there is subjective or objective worsening of the vision, there is soft tissue inflammation, there is worsening in the motility or worsening in the proptosis, also suggestive of active. There is independently also suggestive of active. Then coming to severity score, as per this in the thyroid eye disease, the severity score is we are categorized into 3 types. One is mild thyroid eye disease, second one is moderate to severe thyroid eye disease, and third one is the side threatening thyroid eye disease. In the mild eye disease, either if there is only one or more of the following, the condition like minor lead retraction, that is less than 2 millimeter, and another is proptosis for less than 3 millimeter. So if lead retraction less than 2 millimeter or proptosis less than 3 millimeter, or associated with mild soft tissue involvement, or corneal exposure responsive to lubricant, there is no associated diplopia or transient diplopia at present. So in the mild thyroid eye disease, if the lead retraction is less than 2 millimeter, if proptosis is less than 3 millimeter, or if there is transient of the non diplopia, or if there is a corneal exposure that responsive to lubricant, on mild soft tissue involvement, so it can be diplopia. Then coming to in the moderate to severe thyroid eye disease, if lead retraction of more than more than equal to 2 millimeter, or proptosis of more than equal to 3 millimeter, as per above the normal for race or sex, and diplopia, there is presence of diplopia, that is inconstant and constant diplopia also present, and moderate to severe soft tissue involvement. So in the moderate to severe thyroid eye disease, if there is a presence of one or more of the following, that is one is lead retraction more than equal to 2 millimeter, proptosis more than equal to 3 millimeter or above, and moderate soft tissue involvement or moderate to severe soft tissue involvement, and presence of constant or inconstant diplopia, it is coming under the moderate to severe thyroid eye disease. And then it is what is the side threatening thyroid eye disease, if there is presence of dysthyroid optic neuropathy, that is DON, and or corneal breakdown or globe subluxation. So 3 conditions: if there is a presence of DON, that is dysthyroid optic neuropathy, corneal breakdown or globe subluxation, then you can tell it in the severity, in the sight threatening severity score. Then another condition, what is 10 item CAS? So 10 item, that 7 we have already discussed, that is 10 means another 3 conditions. So one is increase in the at least 2 millimeter in the proptosis. If the proptosis there is increment in the 2 millimeter, or decrease in the any movement in the any direction at least 8 degree. If there decrease in the movement of 8 degree in any direction, or third is the decrease in the visual acuity by 2 lines. So what are the another 10 items that when proptosis increase by 2 millimeter, decrease in the any movement, any direction movement less than 8 degree, and decrease in the visual acuity by 2 lines. So what are the limitation? There are some limitation in the 10 item CAS. That is, it requires earlier assessment or mention measures, because previous measurement, as per previous measurement we are comparing in these 3 items, so it requires earlier measurement, which is actually unavailable in the first consultation. Then coming to that same things, that is clinical activity score and the severity score. So it is a revision, like what are the clinical activity score? There is 7 points. So there is 2 pain, that is pain at rest and pain at eye movement, and redness, 2 redness, that is palpebral redness and conjunctival redness, and 3 swelling, that is swelling of the eyelid, swelling of the conjunctiva or chemosis, or swelling of the caruncle or plica. So 1 point is given to each item. Okay, then what is inactive? Inactive CAS score 0 to 2. If CAS score 3 or 3 to 7, or 3 or more than 3, it is known as active Graves ophthalmopathy or active Graves orbitopathy. So then coming to severity score as per UGOGO classification that we discussed already: mild, moderate to severe, or sight threatening. In sight threatening we discussed if there is presence of DON, dysthyroid optic neuropathy, corneal breakdown, and another is globe subluxation we discussed. And in moderate to severe Graves ophthalmopathy, if 2 or more point that we discuss, if there is a lead retraction more than equal to 2 millimeter, exophthalmos or proptosis more than 3 millimeter above, and there is inconstant or constant diplopia, or moderate to severe changes, inflammatory changes. So this is under the moderate to severe category of severity score. And mild we already discussed: lead retraction less than 2 millimeter, exophthalmos of less than 3 millimeter, or proptosis less than 3 meter, and intermittent diplopia is present or no, there is no or intermittent diplopia is there, or inflammatory changes are mild, and there is a negative there is very less or mild negative impact on the quality of life. Then another severity score as per the no specs classification. What is no specs? No means N for no sign and symptoms, and O for only signs and no symptoms, and S for soft tissue involvement, P for proptosis, that is exophthalmos, and E for extraocular movement, muscle involvement, and C for corneal involvement, S for sight loss or the dysthyroid optic neuropathy. So what is the severity score as per the non specs? Non specs is no signs, no signs, no symptoms. O for only signs, no symptom. Then S for soft tissue involvement, P for proptosis or exophthalmos, then E for extraocular muscle movement, muscle involvement, extraocular muscle involvement, then corneal involvement, then sight loss, or that is the dysthyroid optic neuropathy. Then coming to what are the characteristics of the high risk thyroid eye disease. When we will tell it is a high risk of thyroid eye disease, when the patient is male sex, tobacco smoker, and age more than 50 years, then it is in the high risk. And if history of unstable thyroid function and presence of diabetes mellitus, and there is radioiodine ablation or radioiodine therapy in the past 6 months, and progressive symptoms and signs of thyroid eye disease, and if there is orbital aching or orbital pain is there, or diplopia is present. So in the history, if there is unstable thyroid function, diabetes mellitus, radioiodine in the past 6 months, progressive symptoms or signs of thyroid eye disease, if there is orbital aching or diplopia. In the examination, we will find if there is a soft tissue inflammation, if there is presence of soft tissue inflammation, lagophthalmos, defective closure of the eyelid, that is if there is lagophthalmos is there, or impaired ocular motility, or particularly in the elevation that defect, there is impaired ocular. Coming to the CT scan of the orbit, this is the CT orbit. We are showing the extraocular muscle, and this is the optic nerve. So we can find this is the there is a thickening of the This is the medial rectus, this is the inferior rectus, there is a thickening, and this is the optic nerve. There is no compression of the optic nerve by the thickened muscles. Here also this is the medial rectus and this is the inferior rectus. So this is the city of orbit in the coronal section showing the muscle thickness. And this is the same picture in the axial view. So here this is the extraocular muscle, so you can see the muscle belly are thickened. Here the muscle belly are thickened, and there is no tendon involvement. So there is tendon sparing is present in the thyroid eye disease, but there is thickened extraocular muscle involvement. Then coming to what are the indication for the imaging in the suspected or the confirmed thyroid eye disease. What are the indication of imaging? If we have to use the imaging for exclusion of other disease in the atypical thyroid eye disease, like when the patient is euthyroid without any history of thyroid dysfunction, or clinically or unilateral patient having unilateral thyroid eye disease or markedly asymmetrical eye disease, and there is absent upper lid retraction, or there is a upper lid ptosis is there, or atypical strabismus or severe orbital pain. So in this condition we have to exclude the disease, like euthyroid condition if there is a unilateral condition, upper lid retraction, upper lid proptosis, atypical strabismus if severe orbital pain. And assessment of confirmed thyroid eye disease, like is sight threatening eye disease, or planning for orbital or some cases strabismus surgery. In the confirmed thyroid eye disease, if any sight threatening condition, then you will go for imaging study, and if you are planning for orbital or some cases strabismus surgery, you can go for imaging. Then coming to this management thing, how will manage if what is the management measure in the all the patient, all patient we have to ask to stop smoking. Second, correct the hyperthyroidism and the hypothyroidism, correct the hypercholesterolemia, use of artificial tears or ointment, and refer to specialist center. So all cases we have to avoid the smoking, and correct the hypothyroidism, correct the hypercholesterolemia, artificial tear usement. And then we come to how to treat the mild Graves' ophthalmopathy, then moderate to severe or active Graves' ophthalmopathy, moderate to severe inactive, and sight threatening Graves' ophthalmopathy due to dysthyroid optic neuropathy. So in mild cases we will go for watchful strategy, the selenium supplementation we can give, and intravenous glucocorticoid only in the selected patient, and rehabilitative therapy if required in the patient. Once it becomes stable or inactive, then we will go for rehabilitative therapy. Then moderate to severe or active Graves' disease. So the first line treatment is the intravenous glucocorticoid therapy. So high dose of oral glucocorticoid, oral glucocorticoid are the alternative, but it is less effective. So in first line is intravenous glucocorticoid therapy. In the moderate to severe active Graves' ophthalmopathy. In second line, second course of intravenous glucocorticoid, oral glucocorticoid combined with orbital radiotherapy or cyclosporin, or other modality of treatment like rituximab, tocilizumab, or teprotumumab we can give. So then coming to moderate to severe or inactive thyroid eye disease, we can go for rehabilitative surgery, or orbital decompression surgery, squint surgery, or eyelid surgery. Then in the sight threatening Graves' ophthalmopathy or DON, that is dysthyroid optic neuropathy, we can go for massive doses of intravenous glucocorticoid, orbital decompression, especially in cases of absent or poor response. We can go for orbital compression therapy in the sight threatening Graves' ophthalmopathy or due to dysthyroid optic neuropathy. So again we have to revise that things. The overall the approach to therapy: first, local lifestyle measure will ask all the patient, optimal controlling of the hypothyroidism or hyperthyroidism condition, lubricating the eye drop, eye gel ointment in the night, and another is tapping the eyelids during the when lagophthalmia. When there is incomplete closure of the eyelids, we will ask the patient for tapping of the eyelid in the patient, and wearing of headband, tightening with Vaseline moisturized eye pad also we can use. Then we can advise for the head of the bed elevation, such as sleeping with additional pillow, and photophobia can be managed with dark goggles, and diplopia can be improved with the selective ocular occlusion or some press on the prism. We can use it, and patient can abstain from smoking, and second hand smoke exposure also to be avoided by the patient. Then in the mild cases, selenium selenite, that is 100 microgram twice daily for 6 months. We will advise selenium selenite 100 microgram twice daily for 6 months in mild cases. And clinician should assess regularly the psychosocial impact of the patient, because most of the cases are psychologically, that comes depression because of this of facial appearance. So we have to also assess psychosocial aspect in every visit. Then therapy will, for the moderate to severe thyroid eye disease, will go directly to the intravenous glucocorticoid therapy. It is the preferred modality of the management in the moderate to severe thyroid eye disease. Then how we will give this intravenous glucocorticoid therapy? The intravenous methylprednisolone will give, the cumulative dose is 4.5 gram over 3 months. So total over 3 months we have to give the 4.5 gram of cumulative dose. How will give? That is 500 milligram 500 milligram once weekly for 6 weeks. Okay, 500 milligram once weekly for 6 weeks you will give. Then 250 milligram once weekly for another 6 weeks. So total 4.5 gram we have to give. So 500 milligram weekly for 6 weeks, then 250 milligram weekly for another 6 weeks we will give intravenous methylprednisolone. Then if there is poor response to methylprednisolone at 6 weeks of therapy, we will assess if there is poor response, then we can withdraw the therapy and evaluate for other therapy. And clinicians should be alert for the worsening of the diplopia. You have to check diplopia every visit. Worsening of diplopia or onset of dawn, that is dysthyroid optic neuropathy, while on IV methylprednisolone therapy. And another thing we have to remember, IV methylprednisolone therapy dose should not exceed 8 gram. So you have to avoid then coming to other drugs like rituximab and tocilizumab. These two drugs we can give in the, when there is inactivation in the glucocorticoid resistant patient in the moderate to severe active thyroid eye disease. When there is glucocorticoid resistance, we can give tocilizumab and rituximab. Another drug is teprotumumab. Teprotumumab we cannot use in this condition of glucocorticoid resistance. Only we can use rituximab and tocilizumab. Then teprotumumab is a preferred therapy if it is available in the active. It is in the active moderate to severe thyroid eye disease with significant proptosis or diplopia, but it is not indicated in the glucocorticoid resistant state, but we can use in the active moderate to severe thyroid eye disease. Then coming to this another regarding rituximab, there is evidence from randomized control trial is limited, but regarding the inactivation of the thyroid eye disease for prevention of relapse, in more than 1 year, particularly those who are patient of less than 9 months of duration of the disease, it has some efficacy of rituximab is there for inactivation disease or prevent the relapse after 1 year. And rituximab therapy is acceptable in the active moderate to severe thyroid eye disease with prominent soft tissue involvement. Then tocilizumab, it is acceptable in the treatment with the inactivation of glucocorticoid resistance patient with active moderate to severe thyroid eye disease. Then another modality is radiotherapy. This radiotherapy is treatment in the patient with active to severe moderate to severe thyroid eye disease, those who are having diplopia. And radiotherapy we should be used cautiously in the diabetic patient, and avoid if there is presence of retinopathy, and it is contraindicated those who are less than 35 years of age. It is avoided in the younger patient less than 30 years of age, because there is a lifetime risk of tumor developing in the radiation field. Then coming to rehabilitative therapy, also this is you can advise in the moderate to severe thyroid eye disease, and and it should be performed when this disease is inactive and euthyroid has been achieved. Then for therapy for the side threatening thyroid eye disease, the patient with dysthyroid optic neuropathy required IV glucocorticoid therapy with close monitoring of the response after 2 weeks, and consider the decompression surgery if the baseline visual function is not restored. We'll go for in the dawn or the side threatening thyroid eye disease, we'll go for IV glucocorticoid therapy and check the response after 2 weeks. and consider the decompression surgery if there is a decrement in the visual function. And radiotherapy may be considered for preventing or urgently treating of the dysthyroid optic neuropathy. Also we will advise radiotherapy. Then the compressive then with compressive down or orbital decompression or the deep medial wall or the orbital floor should be considered to restore the vision by reducing the apical compression on the optic nerve. So surgical therapy like decompression of the deep medial wall and orbital floor should be considered to restore the vision reduced by the apical compression of the optic nerve. then we'll discuss regarding the medical therapy. Then we'll discuss regarding the dosing schedule of this medical therapy. The dose schedule of IV glucocorticoid will give 500 milligram once weekly for 6 weeks, then 250 milligram once weekly for another 6 weeks. Then oral glucocorticoid per oral we can give for 3 months 100 milligram of prednisolone daily. Then we can taper the dose. Total cumulative dose we can mycophenolate mofetil. Then mycophenolate mofetil, this is per oral, will give 0.72 gram daily for 20 per week. 20 per week means 6 months. For 6 months we will give. And rituximab IV dose 1 gram. 2 doses for 1 weekly. For 2 weeks you can give, or 500 milligram single dose, or 0.1 gram. 0.1 gram single dose we can give. We will discuss this later regarding the rituximab therapy. Then teprotumumab, this is every 3 weekly for 6 months. We will give every 3 weekly, in 21 days. For every 21 days we will give for 6 months. First dose is 10 milligram per kg and subsequent dose is 20 milligram of kg. So total 8 infusion dose we will give. So teprotumumab we can give every 3 weekly for 6 months, every 21 days for 6 months. That is first dose 10 milligram per kg, then subsequent dose 20 milligram per kg. And tocilizumab, this is IV, we will give 8 milligram per kg for every 4 weekly for 12 weeks. That is 4 doses we have to give. 8 milligram kg for every 4 weeks, 8 milligram kg for 4 weeks for 12 weeks. That is total 4 days of tocilizumab we can give. Then we'll check for some adverse effect of drugs. IV glucocorticoid, the more frequency of side effect is hyperglycemia. Other concerns like GI symptoms, hypertension, weight gain, infection, psychosis are there. In oral glucocorticoid also more frequency GI symptoms, hyperglycemia, Cushing nut fissures, weight gain. And in MMF the most frequent are infection, hepatitis. And MMF for glucocorticoid, GI symptoms are more common. Then in rituximab, infusion reaction is the more common. And teprotumumab, this is GI symptom, hyperglycemia, hearing loss, inflammatory bowel disease aggravation in the teprotumumab. Then tocilizumab, fatigue, hyperlipidemia, neutropenia, infection, hepatitis are common. So fatigue, hyperlipidemia, neutropenia, infection and hepatitis. Then we just discuss some clinical situation. In some various situations, if the patient is unresponsive to glucocorticoid therapy, we can go for radiotherapy or rituximab or tocilizumab. The patient, if it is non-responsive to glucocorticoid therapy or intolerant to glucocorticoid therapy, will go for radiotherapy or rituximab or tocilizumab. And the adult patient less than 35 years will avoid the radiotherapy. Other modality we can give for less than 35 year age. If there is chronic infection, we can go for radiotherapy. We can go for teprotumumab. Other things we can avoid. If the patient having chronic liver disease, we can go for radiotherapy, rituximab and teprotumumab. And if the patient having active GI disease, we can go for radiotherapy. And if cardiovascular disease, we can go for MMF, and we can go for teprotumumab, we can go for tocilizumab. If diabetes mellitus, we can go for mycophenolate mofetil, and then we can go for rituximab, we can go for tocilizumab. In CKD, we will avoid MMF, we will go for other modality of treatment. In CKD, we have to avoid MMF. In radiotherapy we can give only we can give in unresponsive to therapy to glucocorticoid, and we will avoid in less than 35 year in radiotherapy. Okay, this condition we have to discuss, and less than 35 pure we can go for all the things except the radiotherapy. Then just to summarize all these things, that thyroid eye disease, we have to first diagnose the Graves' disease, accurately measure the TRAb, then restore the stable euthyroidism, avoid smoking cessation, local measures, and report to specialty care. Then we will assess for the thyroid eye severity. It is severity and activity score. We will assess the quality of life based on the disease activity, severity, duration, trend of across the time, impact of on the quality of life and treatment goal, and patient age and comorbidity. This comorbidity already we discussed, and patient preference and availability of therapy. Will either it may be active phase or inactive phase. The treatment goal, we have to improvement of the quality of life and promote the thyroid eye disease remission and prevention of the disease. So the medical therapy is watchful monitoring in the mild cases, and selenium we can give for 6 months. That is 100 microgram twice daily for 6 months of selenium we can give, and acceptable therapy we can give oral glucocorticoid therapy. And if it is inactive or stable disease, you can go for corrective surgical procedure including orbital decompression therapy, correction of the eyelid retraction, and blepharospasm. Then if this disease is moderate to severe thyroid eye disease, either it may be active or progressive disease or inactive or stable disease. In active disease, if the treatment goal is disease inactivation or soft tissue, there is involvement in reduction in the soft tissue involvement, so the preferable therapy is the IV glucocorticoid, and other therapy, radiotherapy, teprotumumab we can give. But if there is stable disease or inactive disease, orbital decompression or blepharoplasty we will go for. For disease inactivation and diplopia, we will go for teprotumumab, and for reduction of proptosis also we will go for teprotumumab. And if eye motility improvement, we will go for IV glucocorticoid therapy. Then radiotherapy plus or minus IV glucocorticoid, oral glucocorticoid, or teprotumumab. And for surgical intervention, we will go for selective surgical ocular occlusion or adhesive prism we can give, and other surgery like strabismus surgery, permanent prism we can give. And for reduction of the lid aperture, we will go for surgical intervention like botulinum toxin injection, subconjunctival levator glucocorticoid therapy, or tarsorrhaphy we will go for, and eyelid correction therapy we can go in the reduction of the lid aperture. Then coming to the side threatening condition of thyroid eye disease, side threatening, that is the active phase or the progressive disease, here we will preferably will go for the IV glucocorticoid therapy, and therapy dose is 500 milligram once weekly for 6 weeks, and then 250 milligram once weekly for another 6 weeks. And acceptable other therapies like radiotherapy and IV plus or minus IV glucocorticoid. And surgical intervention will go for orbital decompression therapy. And if also if there is presence of stretch optic nerve neuropathy, we will go directly orbital decompression or lid retraction correction. And if corneal compromise is there, then lubricant or topical antibiotic you have to give, bandage, and tarsorrhaphy. If corneal exposure, then lubricant or topical antibiotic, bandaging, and thank you. This is all about the management of thyroid eye disease. Thank you.